All right, everyone. It is 12:01, so we can get started here today. Good afternoon, everyone. Welcome to the University of Washington Internal Medicine Grand Rounds. I hope everyone's having a wonderful week. My name is Hao Tong, and I'm the inpatient chief resident at the University of Washington Montlake campus. Today, I am excited to have the opportunity to present our speaker, given that we've worked together in the ICU in the past. Dr. Pavan Bhatraju is an assistant professor in the Division of Pulmonary Critical Care and Sleep Medicine. He's co-director of the Sepsis Center for Research Excellence and a member of the Kidney Research Institute. He graduated from Duke University with a degree in political science. He did his internal medicine and chief residency at New York University, fellowship in pulmonary and critical care at the University of Washington, and completed a master's in epidemiology at the University of Washington. Dr. Bhatraju clinically attends at the Harborview Medical ICU and the Pulmonary Consult Service. His research interests include studying the epidemiology and pathophysiology of sepsis and acute kidney injury in critical illness patients. Dr. Bhatraju's talk today is called Molecular Phenotyping of Sepsis-induced Acute Kidney Injury, Implications for Precision Medicine. As we go through our session today, I want to invite everyone to submit questions in the chat below, and we can discuss them at the end during our Q&A session. So with that said, welcome, Dr. Bhatraju.
Thanks, Hal. You can see the slides okay?
I can.
Perfect. So thanks, Hal, for that introduction, and I want to thank the organizers for the opportunity to present. And especially I want to thank people for taking time out of their day-to-day to come attend Grand Rounds. I have no disclosures. And then up front, I wanted to make some acknowledgments of people who have helped me in my research career, and as well as collaborators. And I want to start with Laura Evans. Laura's in the Division of Pulmonary and Critical Care at University of Washington. But when I was at NYU as a chief resident, she was my first research mentor and really showed me the joy of academic medicine. And she was really the first person to suggest coming out to Seattle to do a pulmonary and critical care fellowship. Next, I want to thank Mark Werfel, who's in the Division of Pulmonary and Critical Care, and Jonathan Himmelfarb in the Division of Nephrology. Both of them have been my research mentors since I started fellowship, and they really planted this seed of studying acute kidney injury in the critically ill. And now I joke that the kidney is my muse. And then I want to thank Conrad Lyles, who's provided academic mentorship and navigating a career in academic medicine. And then Brian Kastenbaum in the Division of Nephrology, who's taught me a tremendous amount about epidemiology, study design. And then finally, I want to thank Leela Zelnick. Leela's a PhD biostatistician. She's the director of the biostatistics at the Kidney Research Institute. And Leela has done a lot of the analyses that I'm going to be presenting and has taught me so much about biostatistics, interpreting study results. And it's really been a team effort with the research I'm going to present. So for the overview of the talk, I'm going to first talk about sepsis-induced acute kidney injury, then go over the heterogeneity in AKI and why potentially it could be a problem. Talk about one methodology we've been developing, latent class analysis, and how we use that to identify AKI subphenotypes. And then go over some of the clinical and research implications, and then finally ending with some limitations. So what medicine grand rounds wouldn't be complete without a case? So we're starting with a 65-year-old woman with a 1 week of productive cough, shortness of breath, who presents to the emergency room. She has a history of diabetes and stage 2 chronic kidney disease. You obtain a chest radiograph in the emergency room and you identify she has a right upper lobe infiltrate. Then on vital signs and laboratory values are consistent with sepsis. She has a serum creatinine that's 2.5, which is above a baseline of 1.3. She's developing oliguria, blood cultures grow streptococcus pneumoniae. And then there's some clinical and research questions that come up in a case like this. Some of the questions that I thought of were, how do we risk stratify patients with sepsis-induced AKI? who potentially may go on to have kidney recovery versus who need urgent dialysis. Are all hospitalized patients with acute kidney injury the same? Are there potentially biologically different subgroups? What's the optimal volume of fluid resuscitation therapy? Currently, we do a one-size-fits-all model of 30 cc's per kilogram, but are there potentially subgroups that may benefit differently? And then could there be a vasopressor agent that may augment kidney recovery? And then finally, what are the long-term risks of chronic kidney disease and dialysis in patients with acute kidney injury in the hospital? So to talk a little bit about the heterogeneity in acute kidney injury and why potentially it could be a problem. So AKI is the most common form of organ failure in sepsis. And sepsis is defined as an impaired or dysregulated immune response to infection that leads to organ dysfunction and death. Multiple studies have demonstrated that sepsis mortality is decreasing. Here on the right is a figure from an article in JAMA looking at ICU patients with sepsis or septic shock. And it shows the trend that in 2000, mortality was 35%, and with a consistent decrease to 2012. And this was population data from Australia and New Zealand. There's another citation on the right there from the CDC that again demonstrates this decrease in mortality. I think with this decrease in mortality, one of the things we think more about are what are the long-term morbidities that may develop after a hospitalization with sepsis. And particularly acute kidney injury can lead to chronic kidney disease, long-term dialysis, and even risk of long-term mortality. So how can we improve the other forms of organ failure that may occur due to sepsis? And so how do we define acute kidney injury? Currently, AKI is diagnosed and staged based on a change or an increase in serum creatinine or a decrease in urine output. And then subsequent stages of AKI are determined by how severe that increase in serum creatinine is. AKI is extremely common. Some estimates say that 35% of all admissions to the ICU have some form of acute kidney injury. And then mortality is high. So on the right, we have a Kaplan-Meier curve. And with each subsequent stage of acute kidney injury, you have a higher risk of mortality. The other important thing to consider is there's a number of clinical consequences when a patient develops acute kidney injury. For example, there could be electrolyte imbalances such as hyperkalemia or others. There's also challenges with dosing essential antibiotics or other medications and the clearance of these medications. And then edema can develop, either pulmonary edema that leads to respiratory failure or edema in other organs that could lead to shock or other organ dysfunction. There's also biologic consequences from coagulopathy, immunity, and organ crosstalk. AKI also has a diverse pathophysiology. Some of the different exposures can be critical illness, circulatory shock, trauma. There's also different susceptibilities from chronic kidney disease, diabetes. And then the pathophysiology is quite diverse, from cellular injury to inflammation and even maladaptive repair leading to fibrosis. However, despite how common it is in the complications, we don't currently have a proven pharmacologic agent for the prevention or treatment of acute kidney injury. And here's a list of a potential set of patients that we may see in the ICU, all with acute kidney injury. And one of the things I think it's valuable to think about is when we hear these cases, do we really think all these patients have the same form of AKI? So a 77-year-old man with lymphoma who started chemotherapy and now has tumor lysis syndrome, a 35-year-old with pancreatitis, a 40-year-old with staphylococcus bacteremia and endocarditis, a 60-year-old with COVID pneumonia, and then a 50-year-old with a massive transfusion resuscitation protocol due to severe trauma. And I think one of the challenges with AKI is this heterogeneity. And this is not an exhaustive list by any means, but here's a set of clinical trials that have been done in acute kidney injury, testing everything from atrial natriuretic peptide, insulin-like growth factor, high-dose furosemide, or even different resuscitation strategies. And despite having strong preclinical data and even early stage clinical trials that were successful, all these trials were negative in larger phase studies. And I think one of the potential reasons may be we're studying very different populations. So in one of the trials, it looked at patients specifically with acute tubular necrosis. Another trial looked at patients who were requiring dialysis. And then finally, the last trial here that I highlight looked at patients at risk of acute kidney injury with sepsis. Francis Collins, the director of the NIH, stated, "Drug development system in the US is in crisis. While we know the molecular and genetic basis of 5,000 plus human diseases, we have safe and effective treatments for a fraction. 90% of drugs that enter clinical trials will fail, and the estimated cost of a new drug approval is greater than $2 billion US. One reason may be heterogeneity in treatment effect." And so here, this schematic, I think, helps demonstrate this concept. So this is a hypothetical clinical trial, but on this figure on the y-axis is the treatment effect in the clinical trial. And on the x-axis is a specific patient characteristic. So if it's an ICU trial, potentially it could be their severity of illness or their Apache 3 score. Each dot on this figure is a different individual patient. And so you can see that overall, the effect of the therapeutic in this first figure showed a null result. There's no significant difference. In contrast, if we look at this other figure, you see that again, you have an overall null result. But if you look at based on a certain patient characteristic, it seems like patients with the highest, let's say, Apache 3 score may be even harmed with the certain therapeutic that's being studied, while patients in this intermediate range potentially are benefiting, and then patients in the lower range may have no benefit. If we combine all these patients together and study them in looking at the overall effect, potentially we may not identify this subgroup that may benefit from the treatment. Another way to show this is if we have this heterogeneous population of patients with acute kidney injury, potentially there are subgroups that are more biologically similar and that may respond more uniformly to therapies, or a potential subphenotype. So I think this is one of our fundamental problems in studying clinical AKI, and it may limit the identification of therapeutic signals. So then there's been a lot of interest in this idea of precision medicine. And so what do we mean by that? And so I would argue that in medicine, we've always attempted to be precise. And formally or informally, we weigh the benefits of a therapy with the risk and discuss those with the patient on an individual basis. These are just some examples, but in asthma, we think of, can we try to classify patients based on Th2 high or Th2 low asthma? In CKD, do they have albuminuria? Heart failure, do they have a reduced or preserved ejection fraction? Do they have ischemic or non-ischemic? And I'd be remiss not to mention acute kidney injury. Often what we do is identify, do patients have pre-renal AKI or acute tubular necrosis? However, this distinction has some limitations, and I provided some citations here, but some of the challenges are urine microscopy to diagnose acute tubular necrosis can be dependent on the timing of urine sample collection during the course of AKI. The sensitivity of urine microscopy may vary based on AKI risk factors, and the fractional excretion of sodium has poor reliability between these two groups. And then some studies that I've highlighted here, they've had clinical adjudication by expert nephrologists who found that the correlation between 2 or 3 different nephrologists saying, does this patient have pre-renal AKI or ATN, is poor. And so it highlights, is there another way where we can identify subgroups of patients with AKI? And so one methodology we've been working on is called latent class analysis. Our group has been using this methodology. It's a type of statistical analysis that's based on mixture modeling. And it's the hypothesis that there are distinct subgroups of patients within a larger population. The goal of LCA is to identify subgroups that are similar based on known observed characteristics. And latent class analysis asks the question whether the data distribution better fits a 1-class model versus a 2-class versus a 3-class or 4. And I think one of the benefits of this is, unlike other regression-based models, this type of approach can be independent of clinical outcomes. For example, you can use baseline clinical data that is collected prior to enrollment in a clinical trial and see if this data can be used to identify subgroups. There's been an explosion of interest in applying latent class analysis to medical literature. It initially came from the sociology literature, but here are some papers that our group, as well as others, have used applying latent class analysis in ICU populations. So how did we go about doing this? So we had a discovery and validation population. All patients had acute kidney injury based on a rise in serum creatinine. All patients were admitted to the intensive care unit, and for the most part, the majority diagnosis was sepsis. The discovery population was enrolled by Mark Werfel from the Harborview Medical Center, included approximately 800 patients. And then the validation cohort included patients that were enrolled from multi-center, so Massachusetts General Hospital, UCSF, University of Pennsylvania, as well as others. All patients had blood collected within 48 hours of ICU admission. And then we ran in latent class analysis independently in both populations using the same 29 input variables. So we chose variables a priori that have been associated with the pathophysiology of AKI in sepsis. So these were demographics, different comorbidities such as diabetes, chronic kidney disease, ICU level factors, some common laboratory values. And then in our research lab, we used the plasma that was collected to measure a panel of endothelial biomarkers, as well as biomarkers of inflammation. These were particularly chosen because the kidney is such a highly vascular injury, and we wanted to characterize kind of what could be potentially happening. My mentor for this work was Gerald Herting. He's a professor in sociology in the upper campus, and it was his first time working on ICU level data, and so it was a fun experience getting to work together on this project. So what did we find? So when we apply latent class analysis to the discovery population, here we found that a 2 subgroup model best differentiated the data, with approximately 60% of patients in subgroup 1 and 40% in subgroup 2. We then looked at all the 29 variables that were used in the modeling. And here's a heat map with each 29 with their rank order. And we termed the 2 different subgroups AKI subphenotype 1 and AKI subphenotype 2. And so as you can see in the top here, the ratio of angiopoietin 2/1, a circulating biomarker that we'll talk more about, and then also soluble tumor necrosis factor receptor 1, or TNFR1, were the 2 biomarkers that most differentiated the two groups. So then we went to another ICU population that was enrolled the same way. The only difference was these patients did not have acute kidney injury. We measured all the same 29 variables, applied latent class analysis, and found that we weren't unable to identify 2 subgroups, potentially arguing that the previous groups we identified may be specific to the AKI population. Now we went to a validation population. Again, had all the same input variables. And again, here we identified 2 subgroups or subphenotypes. Again, 60% of patients fell into subgroup 1 and 40% in subgroup 2. And then when we look at how the different 29 variables separate between these 2 groups, we find that a number of variables change their rank order, but the top variables were again the ratio of angiopoietin 2/1 and soluble TNFR1. So it's nice that we were able to identify these 2 subgroups in 2 different populations. One of the questions we had was, do they potentially differentiate the risk of clinical outcomes? And so here we're showing hospital mortality. On the x-axis is the discovery as well as the validation cohort. And then in the white bar is looking at all patients with acute kidney injury. And then you can see that when you stratify patients based on AKI subphenotype 1 versus subphenotype 2, there's almost a 2 to 3 times higher risk of mortality in subphenotype 2. This is adjusted for their Apache 3 or their severity of illness, as well as their KDIGO stage of AKI. And we found similar high rates of dialysis as well as renal non-recovery in the SP2 population. Next, we wanted to see, it's challenging for clinicians to measure 29 variables at the bedside and classify patients based on their subphenotype. And so working with Leila Zelnick, she was able to apply lasso regression, a machine learning modeling, to identify, is there potentially a parsimonious set of variables that can identify these two subphenotypes? And Leila was able to identify a 3-variable model that best predicted AKI subphenotypes in the discovery population, and then she locked the coefficients and used that same model in the internal test as well as the external validation. And while the AUC was good in the training set, you can see that there is some decrement in differentiating these subphenotypes, but still it performed pretty well in the validation population. So briefly, I wanted to go over some of the biology behind angiopoietins and thinking about acute kidney injury. This is somewhat of a simplistic schematic, but I think it's a cartoon that helps understand what could be occurring. So briefly, angiopoietin 1 are secreted ligands for the Tie2 receptor. They're found on, the Tie2 receptor is found on endothelial cells. Ang1 is released by parasites and platelets and leads to vascular quiescence. In contrast, preformed Ang2 is released after an inflammatory injury signal and leads to blood vessel destabilization and vascular injury. Ang2 mainly acts as a Tie2 antagonist in septic conditions and plays a role in augmenting vascular inflammation, promoting vascular leak. And then in critical illness, Ang1 levels often precipitously drop while Ang2 rise. And so we think the ratio may be a better marker of endothelial stability. What's also particularly exciting about this pathway is that there's been a number of preclinical studies that have looked at modulating this pathway through different drugs, such as drugs that are agonist to Ang1, antagonist to Ang2, or even agonist to the Tie2 receptor. And in preclinical studies, it's shown to have improved outcomes in sepsis, especially sepsis-associated AKI. And we'll talk a little bit more about some of the other therapeutics coming for this pathway. Sorry about that. So then when we identified these two subphenotypes, a little afterwards, there was a group from Finland. Using their Fin AKI study, they had 301 patients who had sepsis and acute kidney injury. They applied a similar methodology that we did latent class analysis and had a number of similar variables. And they were able to externally validate what we were demonstrating, that their acute kidney injury can be separated into two distinct subphenotypes. So the next question we had was, do these AKI subphenotypes, they're characterized by endothelial function, could they potentially respond differently to vasopressor agents? And so there's been some preclinical data as well as some early phase clinical data saying that vasopressin, it's one type of vasopressor that we use in the ICU for septic shock, that vasopressin may be associated with improved creatinine clearance and increased urine output. And one of the hypothesized mechanisms is that while norepinephrine binds at the afferent arteriole as well as the efferent arteriole, vasopressin may preferentially bind at the efferent arteriole and lead to improvements in GFR. There was a large clinical trial called the VAST study. So this was vasopressin versus norepinephrine and septic shock. I'll on the next slide, I'll talk a little bit more about this, but overall in the VAST study, there was no significant mortality difference between the early addition of vasopressin. However, investigators then went back and looked at if we stratify patients based on if they have acute kidney injury prior to randomization. So that's important. It's before they get randomized. If they had acute kidney injury already, it seemed like there's maybe a trend toward benefit with the early addition of vasopressin. With those findings, the same investigators then did the VANISH trial. This was another large randomized control trial that was published in JAMA in 2017. Again, they looked at norepinephrine alone for the treatment of septic shock versus norepinephrine with vasopressin. And the change here was that their primary outcome was kidney failure-free days. Unfortunately, they found that, again, there was no difference in kidney failure-free days. But if you look at a secondary outcome of need for dialysis, vasopressin was associated with less need for dialysis. So here, going back to the VAST study, so we reached out to Jim Russell as well as Keith Wally, and we were seeing if we could do a secondary analysis of the VAST study. And so to remind people, VAST was a randomized controlled trial that included 800 patients. All patients had septic shock and they already were on 5 micrograms of norepinephrine. One group was randomized to continue monotherapy with norepinephrine, while another group was randomized to the early addition of vasopressin with norepinephrine. Their primary outcome was 90-day mortality. And as you can see in this probability curve, there is no significant difference. So we then went back and identified a random sample of 326 patients with biospecimens. We then identified which one of these patients had acute kidney injury prior to randomization, and that was 271. And then we used the 3 biomarker model that we developed, that parsimonious model that I told you about, and we applied it to the biomarker measurements in this data set. So now this is a third cohort. We've identified 2 AKI subphenotypes using that model. And here, it was almost a 50-50 split with how many patients had subphenotype 2 versus subphenotype 1. And these are our main results looking at this is a forest plot of our main results. Here's the outcome is 90-day mortality. And if you look, the relative risk for all patients with acute kidney injury was not significantly different. The relative risk crossed 1. However, if we stratify patients based on if they're AKI SP1 or SP2, we find that patients with subphenotype 1 had almost a 20% decrease in mortality with the early addition of vasopressin, while patients with subphenotype 2 had no mortality difference. We found the similar results when we look at kidney-specific outcomes, so 7-day renal recovery, as well as risk of dialysis, where patients with subphenotype 1 had improved outcomes with norepinephrine. So again, this is potentially suggesting if we lump all patients with acute kidney injury together, maybe we're missing a treatment signal that may be specific to a particular patient population. So this was exciting. It was the end of 2019. We just published that work and we had a lot of directions where we wanted to take it. However, as many can remember, early 2020, COVID-19 happened and we started seeing a lot of cases in our area. And so this line of research paused. And I remember early in the pandemic in March, we had our last pulmonary section meeting at Harborview. And Carmen Mikasinik, who is now faculty at Benaroya Research Institute, but who was at Harborview then, her and I were talking and we're saying a lot of our colleagues from around the country had been asking us about what's been happening in Seattle. We're hearing a lot of stories about how sick patients are, and it made us think, you know, we should really write our early experience. And so we reached out to friends and colleagues at Valley Medical Center, Swedish Hospital, Virginia Mason, and we put together a case series that was published in the New England Journal. And really, this is really the only time where you can have 4 IRBs approved, data collected, analyzed, and potentially published all in 5 weeks. And I think I'll be the first to acknowledge that this is probably going to be one of the shortest case series to be ever published in the New England Journal. But I do think one of the things we highlighted was just the high mortality that we were seeing with COVID-19 and the long stays on mechanical ventilation, and potentially sounded the alarm that COVID is not like another influenza pandemic, and that the poor outcomes we're seeing in China were not specific only to China, but were occurring here. This is my last slide on COVID-19. But after that, we developed a prospective observational cohort study that enrolled patients at Harborview, University of Washington, Montlake, as well as Northwest Hospital. This was a collaboration with Eric Morel, Mark Werfel, Laura Evans, Carmen Mikasinich, Owen West, as well as many others. And the thing I wanted to highlight most about this experience was, to me, it really demonstrated how siloed we could be in research. And so, early in the pandemic, almost everyone's research program stopped other than people who had already been studying sepsis or COVID-19. And so we were able to collaborate with a lot of people across the School of Medicine who brought many different ways to think about sepsis and ideas to it. And so some of the examples, we collaborated with Aaron Lee from ophthalmology and working with Microsoft AI for Health, where we're able to interpret radiology imaging and clinical data. We also worked with basic science nephrologists, immunologists, radiologists, and it really highlighted to me the importance of trying to develop these collaborations outside the Department of Medicine and across the school. And so Conrad Lyles has been working on this for a while, but it solidified to me the importance of having a dedicated center that studies sepsis-related research. And so recently, the University of Washington School of Medicine sanctioned the Sepsis Center of Research Excellence, or SCORE UW. This center brings together investigators from the departments of medicine, surgery, ophthalmology, pediatrics, and radiology. We also have collaborations with industry. So Microsoft AI for Health, working with their data scientists, as well as their infrastructure, and then also Roche Molecular Diagnostics. And I'll talk a little bit more about the partnership with Roche. On the right here, I included the URL, and Amy Fields did a terrific job developing this website. And so if people have an interest, please reach out, and we definitely want to add more members to SCORE. Okay, so now back to phenotyping acute kidney injury. So what are the next directions we could take this work? One of the ways is, if we improve the precision with identifying populations with AKI, potentially we can leverage that to understand genetic risk. And so we've published a paper looking at that. The other thing I think we could do is, and one of these questions that comes up often is, you use blood biomarkers to identify AKI subphenotypes, but what's happening at the kidney and urine level? And so we just got a R01 funded to look at this. But one of the challenges has always been, rarely are kidney biopsies completed as part of clinical care in patients with sepsis-induced AKI. So we really lack knowledge on what's occurring on the molecular level in AKI. Most of the current understanding we have has been extrapolated from animal models of sepsis, in vitro cellular studies, or post-mortem observations. So in response, the Kidney Precision Medicine Project was developed by the NIH. And it's a very ambitious project. The goal in KPMP is to develop a kidney atlas, but it's to do kidney biopsies on patients with acute kidney injury as well as chronic kidney disease. And I know initially there was a lot of hesitancy to think, could we really do kidney biopsies on patients with AKI? There's been now almost 50 biopsies done on patients with acute kidney injury. And we submitted an ancillary study to use the AKI subphenotypes we've identified but then link that up with the kidney biopsy tissue, the histopathology, the single cell RNA-seq, the urinary proteomics, to understand what's happening at the molecular level. The other direction to take this work, I think, is what we demonstrated in VAST, but trying to use these subgroups to potentially identify the right patients for the right therapy. And so we're working on an analysis, a secondary analysis of the CLOVERS trial. CLOVERS is a large randomized control trial that stands for crystalloid liberal or vasopressors early resuscitation and sepsis. And so it randomized approximately 1,400 patients to either a restrictive resuscitation arm and early vasopressors, or a liberal or usual care, but liberal resuscitation fluids and late vasopressors. And this was early after identification of septic shock. Almost 90% of patients were enrolled in the ER. So our question was, potentially, do these different AKI subphenotypes respond differently to the amount of fluid that they're receiving? And this is in collaboration with Nick Johnson as well as Terry Huff, who were site PIs for this study here. And now Terry Huff is a division head at OHSU. And we've already started working on some of the CLOVERS data. And Aisha Khader, who's a second-year internal medicine resident, has been looking at the data and doing an epidemiologic analysis. And so of the 1,455 CLOVERS patients, she's identified that 63% of patients had acute kidney injury prior to randomization. Again, highlighting just how common AKI is in this population. And then she's still working on more analyses, but here are two figures that are looking at the probability of renal replacement therapy. And they're stratified based on the figure on the left is including patients without acute kidney injury. And then the figure on the right are patients with acute kidney injury. And the dotted line are patients who received the restrictive fluid strategy. And as you can see here, one of the big kind of observations is that it looks like the curves flip, and that a restrictive fluid strategy may be beneficial in one subgroup, but may be harmful in another. The p-value for interaction was not significant, but Aisha is doing additional analyses looking at this data. And I just wanted to highlight, she's going to be presenting this work at our American Thoracic Society. She was invited to give an oral presentation. So congratulations. And then the other direction to take this is, how can we get this, how can we get the ability to identify these subgroups to the clinicians at the clinical bedside? And I think that's one of the big challenges, and I've learned a lot about this over the last few years. Initially, I thought that taking a biomarker assay from the research lab to the clinical setting was not as hard as I'd previously known. And so what are some of the challenges with our research measurements? So in the research lab, it takes 4 to 6 hours to measure one of these biomarkers. We often measure them at 80 samples during one time, and there potentially could be issues of batch effect. And so because it was so hard to translate this into a clinical setting, we teamed up with Roche Diagnostics, who that's their expertise, is developing molecular diagnostics. And so talking to Roche, they had a mature assay for Angiopoietin 2, interleukin 6, as well as another circulating biomarker, soluble triggering receptor expressed on myeloid cells, or TREM1. While it wasn't TNFR1 that we've done most of our research on, being pragmatic, we're going to be working with TREM1 and seeing if we can still predict these two AKI subphenotypes. Independently, Neha Sathe, a senior pulmonary research fellow, has been looking at circulating biomarkers that are associated with risk of kidney events in patients with respiratory failure, thinking about this kidney-lung crosstalk. And interestingly, from the list of biomarkers she looked at, TREM1 was one of the ones that was most strongly associated with kidney-specific outcomes, suggesting that even though Roche has that assay that's more mature, it may help us to identify these subgroups. And so the project here is doing first using bank samples, running them on the Roche machine, and trying to identify the correlation with our research measurements. And then eventually doing a pilot feasibility study where we prospectively enroll patients from the ICU here at Harborview, collect a blood specimen, bring it back to our lab, use the Roche instrument to have a readout of what type of acute kidney, do they have AKI subphenotype 1 or 2? And then potentially we could bring that back to the clinicians to potentially inform a future clinical trial. In this pilot feasibility, there's no intervention, but it's still to show the feasibility of doing this phenotyping in real time. And this is a little bit about what I talked about how a potential future clinical trial could go, where once we identify two different types of subphenotypes, could it inform which volume of fluid resuscitation, which type of vasopressor medication, timing of dialysis, or even could we focus on specific therapeutics that target the Ang-Tie2 axis? And COVID has been a true accelerator for testing therapeutics in hospitalized and critically ill population. And one example of this are the therapeutics that modulate the Ang-Tie2 axis. So Eli Lilly, as well as another pharmaceutical company, Airpio, have two different drugs that were tested in early phase clinical trials in COVID-19. Unfortunately, the full results haven't been published yet, and it sounds like both trials were ended early, either for low recruitment or maybe even harm from the medication. But I think one of the things I've been trying to highlight here is that if we include all patients with a heterogeneous population, potentially these drugs may not be effective. And maybe identifying subgroups may help us to identify a population that benefits. So coming back to some of the research questions that we talked about at the beginning of the talk, I think that if we could have improved precision with how we think about different subgroups of acute kidney injury, it may help us inform how we tailor some of the therapies that we commonly use in the ICU for patients with septic shock and AKI. In the end here, I wanted to highlight some of potentially the limitations that come up with this work, or kind of this line of work in that we hear about. So one thing I hear often is, are these the only AKI subphenotypes? Are there other ways to parse out the AKI population where you identify different subgroups? And I think the first answer I have with that is, of course, there's probably many different ways to separate the patients with acute kidney injury, and that each way may have its own benefit, and it's really focused on what you're looking at. And so some of the other work we've done, we've looking at the trajectory of serum creatinine early after acute kidney injury. So who are the patients that quickly resolve versus who are the patients that persist after 72 hours? And when we do that, we find that early 72-hour period is strongly associated with what happens to patients long-term in the development of chronic kidney disease. And so here's a survival plot, but you see that even the median follow-up was 5 years here. What happens in that early 72-hour period can be predictive of what happens long-term. The other way we've been looking at subgrouping patients with AKI is looking at a completely distinct function of the kidneys, or tubular secretory clearance. It's an essential process that eliminates protein-bound substances, such as commonly administered ICU medications, such as antibiotics, sedatives, as well as diuretics. However, when we measure serum creatinine, it doesn't directly assess tubular secretion. So here we did a pilot study in a cohort of 150 ICU patients, and we collected timed blood and urine at the same time in these patients, and use a liquid chromatography mass spec instrument to quantify 7 different organic solutes. And we found that the assessment of proximal tubular secretion provided additional diagnostic and prognostic information and was not perfectly correlated with serum creatinine. And so on this figure, if you look at on the x-axis is serum creatinine, in patient A here with a creatinine of 1, they have a very high tubular secretory function, while another patient with also a creatinine of 1 has almost one of the lowest tubular secretory functions in the cohort. And this has led to a grant that we're doing now. It's with Vanderbilt as well as University of Washington, where we're doing this in a larger multi-center cohort and helping to really hopefully develop algorithms where we can better dose essential medications in the ICU. And then the other limitation is potentially this conflict between precision versus public health. And so this was, these were 2 publications that were published in the New England Journal, I think now almost 2 years ago. But the one on the left is looking at a polypill, so a combination of atorvastatin, amlodipine, and losartan, and hydrochlorothiazide. And the one on the right is looking at a genotype-guided treatment approach for patients post-PCI. And so one of the ways I think about this is that in acute kidney injury, if we had multiple pharmaceutical agents that worked, it'd be terrific to develop a polypill. But unfortunately, we haven't really identified therapeutics that are effective for large groups of population. And so I think we're going to have to do a more precision approach until we identify those treatment strategies. All right, so in conclusion, AKI is a heterogeneous clinical syndrome, and the heterogeneity may be obscuring our attempts to find effective pharmacotherapies. And I think by identifying subphenotypes, potentially we're leading to prognostic enrichment, where we identify patients that have higher risk for poor outcomes, or it could even lead for predictive enrichment. This idea that we identify subgroups that have potentially similar biology and may respond similarly to therapeutics. And so some of the take-home points, the heterogeneity, as I talked about in AKI, how we've used one methodology called latent class analysis to identify 2 AKI subgroups. And we've shown that these 2 subphenotypes have different genetics, clinical, and molecular profiles, and they have different prognosis, and most importantly, response to therapeutics. And that sepsis-induced AKI may be based on molecular classification. And that finally, I just wanted to add that many of these concepts are additive, and there's probably no one best approach to identify AKI subgroups. There's a number of people I want to thank. Here's a list of, and if I forgot anyone, I'm sorry. I also wanted to thank the different consortiums that we've been privy to be part of, including Assess AKI, the Severe Acute Respiratory Illness Consortium, COVID-19, the Clovers Consortium, and then KPMP. And then finally, I wanted to thank all the research coordinators and research scientists who worked in our labs, and especially the patients who've been willing to participate in this research. And with that, I am done. And if anyone wants to provide an evaluation, feel free.
Ooh, that was great, Pavan. Thanks so much for your talk today. It really highlights the potential breaking down like patient populations down to the genetic level in order to help us prognosticate and guide management. We have a couple of questions in the chat box. The first one was from someone who is wondering, what are the clinical characteristics of the patients in the 2 angiopoietin subtypes? Specifically, if you noted any factors such as infection or infectious pathogen or location, comorbidities that were associated with the 2 subtypes that you looked at.
Yeah, it's a terrific question. I think one of the, it's a great question. One of the things to highlight is most of the cohorts we've looked at, most of them had bacterial infection or aseptic. We didn't really have that many viral infections. But some of the comorbidities that led to this different was especially chronic kidney disease. If they had a lung pulmonary process or primary pneumonia, usually had higher angiopoietin 2 concentrations compared to a non-pulmonary process. And so I think there's probably a lot of factors of maybe one of the things this question is getting at is where is this angiopoietin 2 coming from? And it could be produced by the kidneys, but as well as other organs in the body.
And within the pathogens, did you note that if there was a certain organism that caused higher levels of angiopoietin 2 versus others?
It's also a great question. In the work we were looking at, it was harder to identify a difference. I think there's been preclinical models that are more focused, where they're able to find that different pathogens may lead to different concentrations in angiopoietin 2 levels, looking at kind of Staph aureus versus other bacterial infections.
Awesome. Doesn't look like there's many other questions in the chat box, but I had an additional one. I was just wondering, do you think precision medicine, from a philosophical general standpoint, is where we're going to take therapeutics in the future? What are your thoughts on that?
I mean, I tried to highlight a little bit of that at the end. I think there's varying levels of precision medicine, and I think there's different ways we could potentially take it. And I think one of the parts that I can speak to is being able to molecularly profile patients. I think we'll be doing more often. I mean, already in the outpatient pulmonary clinic, if someone has severe asthma, we're often measuring different biomarkers such as eosinophilia as well as others to look at how do we characterize patients with asthma. And then we use that data to determine what certain therapeutic would they benefit from. And so I think the challenge in the ICU is how quickly of a turnaround time you need that information.
Yeah.
And so I think as more of our diagnostics come to the clinical setting, it's in letting that inform our therapeutics. And, you know, think about how we have lactate and we sometimes trend lactate values to determine are we reaching our goals in resuscitation.
Great. A question actually just popped up here. Are there germline genetic differences identified that stratify the classes of patients?
Yeah, that's a great question. So I didn't get to talk about that work as much, but we had one paper that we looked at some genetic germline differences, and we did find that there are polymorphisms in the angiopoietin 2 gene that were associated with angiopoietin 2 concentrations, and these same polymorphisms informed what AKI subphenotype you fell into. So, however, if you look at what is the how much of your AKI subphenotype was explained by that polymorphism, it was a small amount, but it was kind of a study showing that some of the polymorphisms probably are directing how much different patients, how much Ang2 they produce with a certain stimulus.
I'll give a couple of seconds here to see if anything else pops up. How does angiopoietin 2 and 1 and TNFR respond to vasopressin? Kind of a cross paper question there.
Yeah, no, it's a great question, and kind of saying, like, let's say someone has high concentrations of these biomarkers in circulation, you start vasopressin, do we see a drop in these biomarkers? And I don't have the answer to that yet. That's something that we've been looking at. It is a little complicated in the sense it requires very exact sampling of before and after starting vasopressin medication, but we're currently enrolling a cohort where we can eventually look at that. But it's a terrific question.
We'll have to tell them just to stay tuned. All right. Well, I think we'll close our question and answer session there. Thank you so much for your talk today, Dr. Bhatraju. I really appreciate you taking the time out to update us on all your interests. We hope that you have a wonderful trip down to California for your next conference. But thank you to everyone joining us today for Grand Rounds. We'll see you in 2 weeks.
Thank you.